That you had a short but enjoyable lunch. Today we aim to explore how secure and interoperable data exchange can empower health systems, research and environmental monitoring within the One Health approach, connecting human, animal and environmental health. We'll discuss best practices, technology enablers, EU case studies and how to translate them into actionable steps. Our distinguished panelists, and which I'd like to introduce one by one, because in the 2 hours panel we have, it will be little time to self present. I would like to welcome in this very same order with the topics we want to approach. So the first would be Mr. Peter Drury, Senior Digital Health Consultant within World Health Organization.
Thank you.
Sorana Bocă, President of the Romanian Society of Medical Informatics. Ms. Alexandra Dobre, President of Institute for Acting Aging Association. On the other side, would like to, because we'll have some minutes as well. So let's mix a little bit. Absolutely fantastic, because Mr. Janos Daniel Dalos will be very happy about sitting next to you. Dr. Arne Paine, Chief Technology Officer, co-founder at Clinomic. Mr. Sebastian Stefanigă, Vice Dean and Assistant Professor, West University of Timișoara. And Alessandro Lazar, Chief Executive Officer and Chief Officer and Founder at DocVisor. Did I miss anyone? 2, 4, 6, 7. Mr. Emil Simion, Cybersecurity Expert, SafeTech Innovations. A wide spread of expertise, which allows me to fear a little bit, even if I'm a TV journalist, science journalist for more than 30 years. It's so difficult to tackle such a difficult subject, having only experts around me. Difficult, because usually in Romania, for the foreign guests, I mean, in Romania, within a TV program, usually we have some people sent by the authorities, which they come with a very clean, clear agenda. You cannot be a journalist with them. But here, I do feel in my waters, in my normal waters, just to go on. So, I have split our 2 hours panel in several segments, putting together, let's say, people from the same area of expertise. So, I think it would be better to speak about a little bit about the past, and that means to speak about best practices in health data sharing. Having WHO with us, who can be the most prominent figure as an entity in the whole world about this? WHO. So, Mr. Peter Drury, you have the floor, sir.
Thank you.
Yes.
Okay, that's on. Right, thank you. Let me...
And let's have prepared the presentation as well.
Yep, thank you.
The presentation is being prepared,
Okay.
sir. So, yeah, let's talk about best practices from the WHO.
Just while that's loading up.
Yes,
So,
data sharing for One Health.
thank you very much indeed. So, pleasure to be here again in Romania. I'm a digital health consultant, and I've, for the last couple of years, have been working with WHO, with 2 colleagues on the panel here, helping with others, some of whom may be in the audience, to develop a digital health strategy for Romania. That remains in the Ministry of Health, and we look forward to seeing its emergence soon. But that process has helped me think through, from a strategy point of view, what are actually the emerging key issues around health. And for me, actually, One Health is the dominant paradigm that I think we're shifting towards. So I wanted to take this opportunity to talk through some of the key issues in the context of thinking about examples from Europe. So, first of all, and I'm glad I'm speaking first because it gives me a chance to put up this big slide, but I think it is important that we understand the scope of what we're talking about when we speak about One Health. It isn't just about the health of human beings, it's the health of plants, animals, and indeed the environment generally. And I like this diagram because if you look carefully at it, you can see little prompts and nudges for all sorts of different aspects of One Health problems that there are. You see there's a bat flying around and cattle and sewage coming out from a block of flats there, and heavy industry in the background. So there are all these aspects of the environment that can provide a threat to the health of people and plants and animals. And the challenge for One Health is to figure out how do we, as we move forward, get better at actually combining the knowledge that we have and focusing it on resolving these problems. There's a helpful diagram, I think, in this presentation from Jacob Sinstad, who's a very eminent person in the field. But I like it because not only does it pick up the environmental, plant, animal, human aspects of it, but it also teases out the fact that to pull this together, we have to have the governances, international, regional, national, district, provincial, traditional households, and the actors, regional, international ministries, private industries, academic scientists, animal health providers, communities, which I'll come back to, and humans. So all of these different organisations need to work together to figure out what are the interactions and outcomes that are going on between these different domains. So that is a very significant challenge. And the advice that is coming in the European context, so One Health governance in the EU, there's an operational checklist in there. And I just picked out the top 3 items that they had. So the first up is to introduce top leadership, superior to the different sector heads that convene stakeholders and actors, for example, the Prime Minister, Minister of Finances. Second thing, create a One Health coordination platform, typically top leadership of public health, animal health, agriculture and environment. And thirdly, identify a One Health issue, typically a problem that requires a multi-sectoral approach. And I'll come back to that in a moment as well. If you look at what WHO has produced, they've got this diagram, which I like because it picks out the major issues that are sort of swirling around the way in which we bring these domains together. There's allocation of sustainable funding in the green, competencies in the blue, leaderships, partnerships, governance in the orange, prevention, preparedness in the red, promoting and supporting equitable, inclusive and sustainable solutions, and finally, which is of particular relevance here, building evidence on the effectiveness of One Health through data and research. So I wanted to give an example of a best practice in data sharing. So what the WHO guidance says is that at the national level, governments establish either interministerial committees, which I've just alluded to, or task forces, or ensure that One Health principles are integrated into national strategies and plan to coordinate efforts effectively. Now, the example I wanted to pick out is from Denmark, and it's their DanMap program, which is its approach to surveillance of antimicrobial resistance. And I've put in bold there what I think is a really key thing to emphasise. Since 1995, so they've been on this for 30 years. They've been putting in place integrated cross-sector surveillance of the consumption of antimicrobial agents and occurrence of resistant bacteria in food animals, food and humans. They've called it DANMAP, to safeguard human health. 30 years they've been on this. And on the basis of that data that they've got from it, solid scientific data, the spread of resistant bacteria in food animals, food and humans has been reduced by limiting the use of antimicrobial agents for animals and humans. That is what this process looked like. When you have a look at this diagram, it's not actually that much of a surprise that it's kind of taken 30 years to get that system up and running really effectively. But you'll see that at the top, you've got pharmacies that need to be involved, veterinary practices, feed mills. That's on the antimicrobial consumption side. On the antimicrobial resistance side, you need to be working with slaughterhouses and retail, farmers and veterinary practices, for example. If you look at the bottom, which is data about consumption, so that means community and hospital pharmacies, and so far as the antimicrobial resistance is concerned, also from general practices and hospitals. And data from those sources then is fed up to authorities that are in place to deal with these sorts of issues, which in the Danish context is the Danish Health Data Authority, and they work in close conjunction with the universities and produce register of medicinal product statistics and the Danish Microbiology Database and the Technical University of Denmark. So there are a lot of different organisations working at different levels and agreeing the data standards that are needed to enable what is relevant to be exchanged between them. It takes time to agree. Having got that basis well established now, they're looking to move on. So we were talking about, what is happening now, new technologies that are coming on. And in the Danish context, one of the things they are drawing attention to in this context is genome sequencing, which can make it possible to look at pathogenic bacteria anywhere in the world at the same time and show the results online, for example, using web-based world maps. So you can see on that picture there, we've got the client side with the raw DNA sequences being fed in, the server collecting the data, analysing it, identifying the known resistance genes, predicting ones where they may be coming up to be a problem, and then producing a summary back to the person in the field or in the lab or in the hospital. That's at the national level. Now, the WHO guidance on the local level says, well, locally, we know what's happening nationally. Locally, what they found was local communities across the region of Europe have led One Health initiatives to address health issues at the grassroots level. The actions not only improve health outcomes, but also empower communities. They have in their documentation about 8 or 9 examples of the national, but they've only got 2 of the local. And the one that is of most interest, I think, is the one that is produced, again, local level policy recommendations that have come from the WHO European Healthy Cities Network. And they have committed to operationalise One Health at the local level by pursuing a sustainable development agenda on food, environment, health systems, health literacy, and also by acknowledging that solid, I think, means well established, but also dynamic. Solid partnerships and collaboration are necessary to achieve a sustainable and healthy future. And they're conducting consultations at local level to map out initiatives that successfully combine multidisciplinary and intersectoral aspects of an approach. So just a little plug here for the exercise that will take up the second part of the afternoon, because that's focusing on the challenges around intersectoral aspects. So it is entirely relevant. So let me draw those threads together and talk then about towards, we're not there yet by any means, but steps towards national and local data sharing strategies for One Health. So, as I said before, at national level, the guidance is Identify a One Health issue, typically a problem that requires a multi-sectoral approach. And we've seen what good can be done if you take, for example, AMR in Denmark. But at the local level, this is the main point, really. Potentially, all the One Health issues come together. So, precision is needed. All of those different factors, to a greater or lesser degree, can have an impact at the local level. So how on earth do we find the best ways to engage with people who are working at a local level so that they can take good decisions that mitigate the risks of having a One Health disaster on their hands, that of course can then spread rapidly and become a regional, a national or regional problem. And in Romania, we've got 3,181 localities, of which 2,861 are rural, 217 towns and 103 cities, all wrapped up within 41 counties. Where's their voice? What is it that we are able to say to them, to the mayors of those localities, for example? What are your One Health issues? We don't have, I suspect, those mechanisms in place. Listening to the bottom up is what we're not yet able to do. And I think, in my view, in terms of a significant additional agenda, this is it. We can do everything that we're intending to do, but if that doesn't translate to something that is meaningful to farmers, to health workers, to citizens, we're going to run into continuing numbers of One Health problems. So, questions, what data can be shared? So not everything can be shared. Some things are confidential. But what data can be shared about human, animal, plant and environmental health, including meteorological data? And I've added that in because it's a crucial part of affecting One Health. And I was sorry, to be honest, that in the session earlier on today, just before lunch, when we were talking about health to space and space to health, there was no mention at all of the impact that satellite technology can have and has had on ways of monitoring the environment, not least helping us improve weather forecasting. So what can be shared both locally and to and from national policies? Good quality data going up, and how is it that their advice and guidance can be tailored so it's precisely relevant to the local communities that.
Maybe we have a space.
Yep.
Please stop here because I want to ask Ms. Bolboacă. Professor, you are the president of Romanian Society for Medical Informatics. Do you think that Romania is prepared? Just share, please, the other one, if that's it's not working. Give it to me. This is working as well.
Okay,
Yeah,
the question is?
The question is, do you think that Romania nowadays, from the medical informatics point of view, is prepared to share all this data between the regional level and the local level, as Mr. Dury said?
It depends. It depends on what we want to share. Because if we want to share raw data, my answer is no. And it not be for time and for preparation of the population to understand what sharing their personal healthcare data means, and to take their agreement to share their healthcare data, because without their agreement we do nothing. So I think that we are at the level on which we need to train ourselves of what sharing sensible data means, because healthcare data is sensible health data, and after that to move forward for the good of all, not for the personal good.
Now, let's keep the presentation on screen, please. So, Mr. Dury, coming back to your presentation. We have now a glimpse of what happens in Romania from Ms. Bolboacă opinion, a glimpse. Because when we speak about data sharing, it's very important not only for the experts to work well and to create a framework of exchanging data, but also about the recipients. And the recipients rely on the work of other fields. Yeah? We have here a lot of specialists from the technical field. They will have their moment to speak about it. But when we talk about also elderly groups, we have Alexandra Dobry over there, and elderly groups need what? Assistance from the medical field in order to receive the relevant data. Alexandra, would you like to say something right now? Or? Because you are the president of the Institute for Active Aging Association, and you see WHO, immediately, I keep in mind, WHO is trying to deliver a lot of relevant information to the world, and associations like yours are key important in the field. We saw this during pandemic, also since the war in Ukraine started, and we had this very morning, we had a very interesting panel with very good speakers pointing out all these things. So what is your feeling about this group, elderly groups? How are they in the focus of the medical field, and how are they helped by the medical informatics?
Do you hear me?
Yes.
Is it okay? Since WHO is one of our partners, I can only say that, of course, the elderly are helped by the doctors, and they actually receive support regarding their needs, their medical needs. But of course, that from my point of view, which is both theoretical and practical one, I think we need to do more. This year, we started the national campaign. I want to speak a little bit about it in my speech, but I will say something now about this campaign. We started it in February this year. We went through all over the country, more than 15 cities, big cities, but not only cities, or also counties, and I saw the need. If in the big cities like Bucharest, which is of course the capital and is the place where the elderly have a lot of opportunities, if we go outside Bucharest, we will see that they don't have as much opportunities as here. When we speak about medical support, when we speak about information, when we talk about prevention, it's almost none when this comes to the elderly. Actually, we have a statistics, a national statistics that came, I think, 1 or 2 months ago, that says a very interesting thing, a very interesting fact, is that 1 out of 5 from our total number of elderly in Romania socialize in 1 month with only 3 people: the priest, the doctor, and the postman, when they get their pension cash, not on card, on their cards. So it's a very sad reality, and I think that they have support, just to answer a question and be short, but we need to, definitely we need to do more.
Alessandro wanted to say something.
Yeah, I was actually having a different question, because when we talk about data sharing and sharing electronic health records of patients, we know we have support for technology out there. We can have a decentralized system to accomplish that. It doesn't matter if it's centralized or decentralized. We have technological support to handle that. But my question is, who do you think should have the responsibility to create the technology to support all that? Should be the private sector? Should be government? Should be WHO? Because definitely, you know, it has to be interoperable.
Not WHO at all. That's really not its business at all. And I think it's horses for courses. So my early career was spent in the UK, which is where I'm from, working in the National Health Service there. And we shifted from systems that were provided essentially by the public sector to those which were private sector led. But the scale of that operation was completely mishandled, and we never got the benefits. There are other countries where they've got a much better mix of solutions between public and private. I think it depends on the culture of the countries concerned and of the industry and of the relationships that the government have with the private sector. In some countries, that's not so good. In others, it's very good. Personally, I think it is a really important aspect of government. And when I was in the UK, I was head of the Information Policy Unit in the Department of Health there. And we had about 7 or 8 different stakeholder groups. And one of them was the suppliers. And I used to speak regularly with them to sort of hear what their issues were. And similarly, we had stakeholder groups concerned with patients, including the elderly. So in terms of developing strategy and policy, it's always helpful, I think, to understand what the issues are perceived by the key stakeholder groups. So tech companies, public and private, are certainly...
But maybe something has to be done in the inception part of our education. Maybe West University of Timișoara could say something about the role played by your graduates, because from there, the education toward better information starts. Yes.
So it's working, yeah. Thank you very much.
Just a brief answer,
so
please.
I try to, in the meantime, to create into my mind the answer of my colleagues already. And I'm very happy that Peter is here, because in the last 2 years we work closely to the national health space. And I think to answer to our colleague question, I think we need to have a strongly assumption that the national level, starting from the government and ministry, not from the entire Romanian workspace. And I think the health infrastructure, when we are discussing a lot of having data, sharing data, until when we'll see established the governmental cloud at the national level, or one space for having the data, all data, not discussing only to the health, but economic, law, and so on, educational data. Until that time, we only have discussions and nothing concrete. From our part of view, like from the academia or the research one, anytime when we are trying to focusing to develop some solutions in cooperation with the industry or citizenships, as in the last years raised also the phenomena of living labs, of having living labs, we are facing the data source lacks. So we are trying all over the time to ask other countries to provide, or other partners to provide the data in order to have I don't know, conduct researches on our national data. Yeah.
Right. So I heard being discussed this at the national level, but when we think about this data sharing, I think we should think more towards a global approach. Even though probably the trend is to migrate from global to maybe more national approach, politics and all that stuff. But I don't think that's less important right now. I think when we talk about decentralized clinical data, I think it should be at the global level, and it should have like a structure that it's interoperable at global level, not just the national level. In that way, we can exchange information a lot easier. And for instance, somebody leaves Romania and moves to the United States or to Germany to be able to share their medical files in a safe environment.
Level of the European level, we have the European framework for health data space. So we have the policies. We need to have a sure agreement at the national level that will adhere to this kind of things. We don't have nowadays the specific infrastructure to put all the data together, to share it. On the other hand, I think this is the part of national intelligence. So as we investigated in the last 2 years, this should be managed by the national intelligence.
Professor Bobak.
I had some slides prepared, but it's not the case now anymore. But in the last year, what I did, and I saw many initiatives at the national level of SMEs or different kinds of researchers of coming to different kind of platform. They propose a lot of health platform to share the data. In the last year, we tried to investigate to have a health intelligence national space. I had some slides, but I think it's not the case now. But we should put our work together and to, I don't know, to convince the government and the specialty ministries to have this kind of data sharing space. And I see yesterday that 4 days ago, we have a firm commitment of Endava to take the responsibility of having the cloud governmental cloud in Romania.
Professor Bobaka, please help me clear the path back to Mr. Drury, because he still has from his presentation.
No.
So we wanted to add something.
Yeah, I want to add something because I think we are not in the reality. Today reality is that we have a lot of Romanian citizens that don't have electricity, but we talk about electronic health records, really, in Romania? We have something like that? We talk about sharing data. What data to share? The paper data? How to share the paper data? And where to go with the paper? This is the big problem, because the frame to sharing data is there. We know what to do, how to do, and in which step to do. But
I think technology is there to support all that, and it happened that we already tackled on this approach at Dogvisor, getting all the paper data into a system that it's getting authorized, and then create the entire electronic health record based on paper information and also structured data around it. But at the same time, we have to make steps into the right direction.
Yeah.
Maybe if I can just add to that. So
Yes.
I'm coming from Germany, and maybe some people think in Germany it's a different kind. So it's not. So our healthcare system is vastly paper-based, and we have the same problem here. And I think I will also later go into the topic of the European Health Data Space, because it's a very important initiative in order to build a common Europe sharing this data, and I think that's the only way to move forward. But these obstacles, we have the same situation basically in all Western countries here. So I think the challenges that we are facing here in Romania can be transferred directly to Germany and vice versa, and there's only way to solve this, and this is basically by using technology. And to add on this, having technology to move from paper-based documentation into structured data exists. We just need to apply it, I think. And now is the time where we have all the pieces of the puzzle in place, where we can ultimately find a way to share this data commonly in the European Health Data Space. And that's the only way forward, how we see it, and I think everybody here in the room agrees probably to that.
We'll very soon move to the data people, the people who...
Permit me, I see that data are locked in data silos, and the information must not be only shared but also communicate. And we can do this communication of information using the identification and pseudo-anonymization techniques. And all the time the proprietary of the information must give the consent for sharing the data. There's not only a single sign-on.
Mr. Drury, you still have a few things to say about... Points, yes. National and local data sharing strategies. It's working.
Okay.
Just closer.
Just let me catch up with where I was. There were so that was what data can be shared. And
It's not working.
point that was made.
That one.
Okay, thank you. So what data can be shared locally and to and from national policymakers? So one of the important issues, I think, in data is not just to focus on the analysis side of it, but to pay attention to the data collection side and the people and systems that collect the data. How do they collect it? How are they trained? Why do they value it, if at all? So that was why I made the point, both to and from national policymakers. And to help improve the quality of data, national policymakers need to understand how best to express the guidance that they come to, having reviewed what's been going on nationally, in terms that people locally can understand and engage with, that it makes sense to them. So, precision agriculture, there was a conversation that was had yesterday in the session. The point being made was every farm is different. So how you help farmers depends on how precisely you can tailor your guidance to the soil conditions, the weather, etc., for that particular farm. It's the same in One Health. For a locality, it's the same thing. Precision One Health, I think, is the important thing. So that is kind of predicated on working towards answering the question. So who are the people locally who are the One Health leaders? And who can help coordinate the data locally? So the people who will go to the pharmacies or to the vets or to the abattoirs or whatever. There's an interesting approach that's being proposed, talking about community One Health workers. People, volunteers, who are actually empowered digitally to have kind of first aid advice and guidance on their handheld device, so that sick people or sick plants or sick animals can have their issues addressed, which I think is something well worth thinking through and working and testing. So, my last point. What is the national strategy? And we know how long it can take to develop national strategies, never mind implement them. What is the national strategy for supporting the development of local implementation strategies? So you have a national strategy for local implementation. For local implementation strategies for One Health, I think, are the missing piece in all of this. And I would commend understanding from a research and an academic point of view and from an industry point of view. Actually, what is it that people in the localities, thousands of them, are wanting to know about the One Health issues, not just about human health, but about all the other dimensions, as exampled on that diagram. That's where it comes together. So how can we help them in a tailored way meet their own local requirements? And to me, that is a really important research agenda, not just in Romania, but in Europe and indeed globally. So that's my... You'll be pleased now. I've now got to the end of my slide deck.
I'm very happy because I now have to focus to the data creation guys, you know, the content creators, the people who deliver different strategies from within the framework of funded projects like Agnosis in the morning. Your boss, Daniel, shared some thoughts with us about the programs you are involved in. So related to what Mr. Drury said, from the WHO point of view, from like a wide framework, could you come closer to the local environment and prepare the path for all these beautiful panelists speaking about the development of programs and technologies for data safeguarding?
In all of our projects, just to refer back to the original question what we had earlier, that whose responsibility? I think it's both responsibility. It's public and private. All of our projects where we are involved, we are working with public organizations and private organizations, and together we can make changes. And just to refer back to the paperwork, yes, there are a lot of paper, as you mentioned, there are a lot of solutions for that one. One of the solutions, what we do in our projects, in Idava, we basically aggregate all this information from different data providers and provide this information over to the patient to share this further, this information. So it actually becomes the patient's responsibility to share further with other authorities.
I had a question for him if he was about to attend this panel, but maybe together with Mr. Simon, yeah, you can tackle it. What architecture facilitates safe real-time data exchange in institutional projects? But maybe also should think about an answer afterwards.
Do you want to start?
It's complicated. In Romania, everything is complicated. Any of you?
It's complicated because I think that in each country we need to set up and to think what is important for us as a nation. To take paper-based medical charts and transform them in electronic file, or to collect, starting from now, everything electronically. Because there are two different strategies that need to be addressed differently. Because if the first strategy is focus on the past, the second strategy must focus on the future, and the present and the future. And I think that in the second strategy we need interoperability, while in the first one we need just to collect and transform paper-based in electronic.
Arne, question for you.
Question for me.
Yes.
So I think you have to go both ways, actually. So you have to make sure that everything you have that's relevant, all the processes that are there, you cannot change the world immediately, right? So you have to be sure that all data is stored safely and is then digitally transferred. But the other thing is, as soon as you collect data in an EHR, in a patient data management system, wherever you store it, you need to make sure that this data is utilizable at the end. Because just storing it electronically, we do it for the last 30 years, and most of the data is not usable at all. So the main thing here is not to have it electronically, but the main thing is to have it in a way that it makes best use for all cases in academia, in research, in AI, in all those future things that happen now. And this is the kind of mind shift where also I think the governmental bodies need to step in to make sure that it's not legal anymore to store data in formats that are not compliant to these standards. If we don't do this, and we don't do it in Germany right now, if we don't do it, we will have a disaster in 20 years from now. So that's my take here, and we need to make sure that it doesn't happen, in particular in systems who now move to digital solutions. So
and now with the emerging AI involvement.
Yeah. I mean, you have billions of data points that are there, that are locked somewhere in silos, as you said it, somewhere in the basement of a hospital, that are completely unutilizable. And if you don't enforce this on a governmental level to say, okay, we have international standards to follow. There's HS7 FHIR. It's nothing new. There is SNOMED. There's so many standards that are established. We need to make best use of them in order to be competitive against other markets. Let's plain it.
Mr. Simeon, you are a cybersecurity expert, so...
Yeah, I want to complete. I think there are 5 questions that we must answer regarding the data. The first question is regarding the value of the data. The value of the data from the perspective of the owner, but also from the perspective of the attacker. The second question which we need to answer is who access my data? The third one is where data is stored locally or virtually in several enclaves. The third one, the fourth one, which are the security measures we implement. And the fifth one, but not the least, are these security measures effectively? I think this, if we answer to this question, we can have a profile of our data, and we can protect them with proper measures.
Alexandru, you would like to add something?
Yes, and just to add something really quick here. You're absolutely right. I think the data should be stored properly and should be definitely having interoperable international standardizations like FHIR or HS7, even though probably a lot of the systems, they don't use that. Now we have the technology behind to complete in a way or another. Like AI can structure the data in a FHIR or HL7 format. And we didn't approach that at DocVisor as well, because initially we haven't used FHIR or HL7, so we had to make this transition all the way. And absolutely the problem is who enters the data, right? The doctors spend a lot of time entering information instead of talking to a patient, right? And they spend very few time asking patient about their health condition. They spend more time entering that data in a computer and filling in the forms. So that's why at DocVisor thought about that user experience ahead, so that if we can record the conversation between the doctor and the patient and manage to extract the relevant information in order to fill in the data for him into the form so that they can just apply at the end, of course in a compliant and a secure environment, I think that will create and add a lot of value in terms of data entry and data exchange. And of course, data is really important, but creating just a data entry platform it's not sufficient. You have to have productivity tools like that to support it.
So we can draw one little conclusion from here. Cyber resilience is no longer optional. It's a shared responsibility, both from the private sector and the public one.
Absolutely. So that's why in order to stay compliant, we organize like every year we have a session of security penetration testing for every major release that we plan.
Professor, yes, we are in the same, share the same thought. Now, what academic, I wanted to ask you, what academic or Erasmus Plus projects have advanced cross-border data exchange and research in One Health? Because all this goes to the European health data space, which can act as a backbone for integration.
We are discussing the Romania, I don't know, one specific project in this kind of topics, but if we discuss at the European levels, are many others in the western part of Europe. At the national level, there are many initiatives who are supporting these kind of things. And nowadays, we saw also from the media that Romania will be will have the Giga AI factory. Also, Romania has big national projects for AI where there are multiple pillars, and I have into my presentation one of the pillars is dedicated to the health part, is the Romanian National AI Hub,
so
where there are involved
SMEs,
universities, and so on. But I had a question for my colleagues or for the audience. In terms of data sharing and in terms of digital solutions for health, what do we do with the current digital solutions which are in the hospitals or private clinics? What do we do with them?
You have it.
So yeah, it's...
Let's all pay attention.
So I presented here West University of Timișoara capacity in terms of health, but I don't want to focus on. So we are part of the Romanian AI Hub project, which is a 5 years national project where we are part of other 7 universities and 8 SMEs. And with this announcement, I'll be happy, or we are open to join other SMEs in terms of focusing on this kind of topics. Trustworthy AI, intelligent and autonomous systems, intelligent human-computer interfaces, hardware technologies for AI. And the 5th one is dedicated to the medicine or to the health part, AI in medicine and health. And other 3, AI in cybersecurity and space, AI for smart cities, and AI for the environment. So, and I extracted a few of our directions related to the health, but I don't want to stay on this slide. What I did in the last year is to try to design at the theoretical level, but with the help of other colleagues, for sure, we'll try to implement it. An intelligence health architecture, that could be adopted at the national level. I name it architecture based on intelligence agents, with 5 levels depending on this specialty. And I think, and we should adopt likewise this platform at the national level. Of course, it's just a proposal one. There were multiple proposals from other colleagues from Romania in different kind of conferences, who were presenting on different kind of conferences or other health events. But I think all the platforms that Romania will be adopted at the national level should be interoperable with the current digital solutions. If we don't do this, then we need to miss what already has been done until now, because some of the digital solutions are well done. Not all of them for sure, but some of them are well done. And also, again, I underline and take the opportunity, if there are other SMEs who want to partnering with us in the Romanian AI Hub, we are more than open to, to collaborate. Not only on health solution, as you saw, there are 8 dimensions.
As the academic field is preparing the path, Arne, I would ask you, how can startups innovate while staying compliant with EU data regulations? Because what the academics do, they take care of the regulations, but what the private sector is doing?
I think there is no such, I think there's no such thing as private sectors and public sectors in the healthcare domain. So there's regulation, European regulation, that we all need to follow, independent whether we are a university, a startup, a huge corporation. It doesn't matter in the end, to be honest. So to answer your question, what about what's happening inside the European health data space? For example, we are working actively, I will show it in my presentation, with 3 hospitals that are actively contributing right now into the European health data space in Romania, in Cluj. So it's not something that's not happening. I think we will see it over time, more and more stuff happening in this regard, and I think we are making very good progress in this direction. And the second question here is now, what do we do with all the legacy systems, right, that are existing in the hospital, that are producing billions of data points somewhere? I think there is only way, you need to build up pressure from regulatory side, from the user side, from the governmental side, but also what we see very, very strongly, really from the hospital side. You have to force them to, because otherwise it's the business model of having data silos, yeah? So if we don't actively force somebody to do it, they will never do it. And that was basically one of the reasons we founded our company, because we were so, it was so difficult to get to some data at least, and not even thinking about AI training, yeah? So to sum it up, there is no other way than just, we have regulations in place, we need to make sure that they are actively followed. And it's independent who is the actor. Is it a health body? Is it a governmental body? Is it a public, like a small, medium enterprise? There is just one regulation in place, period. That's it.
Professor Bolbacher, how?
Sorry, at the end, the health, it's in private or in hospital, it's never mind where it's done, yeah? Theoretically, we need to collect all the data that are from health and to put them together and to give them to the world in order to create evidence. Evidence that needs to be translated in healthcare for the person and in healthcare for the community, and why not in healthcare of the European level, yeah. And we're moving with the healthcare. We're moving from Romania to Spain to Italy and yeah, it's important to have the healthcare data with us.
Yes, I wanted to ask you exactly related to this point. How can informatics from your side bridge the clinical accuracy with large-scale data sharing from all around Europe? Informatics keeps a key role here.
The key role here is data. it's essential to have it, the first of it, yeah. After that, we need to have, I agree with my colleague, but I think, in my opinion, that the legislation, to be the law and to be enforced, because otherwise we will do nothing. If you let the hospital or if you let the patient to give the data, you will have nothing in 10 and in 20 years, because we need to change the culture. And this is very hard to be changed. Even if we have, from the technical point of view, all the system that it's working, without filling that system with the data, it's useless to have the system. This is basic.
Since the war in Ukraine started, we have seen, even here in Romania, a few hospitals hit by hackers from this hybrid war. Maybe it's the moment to ask Mr. Simeon, if Europe is ready to handle cyber risks of interconnected infrastructures, because we have developers who deliver things, and we have the public. Are we ready for...
I have anticipated
Emil Simeon presentation.
This type of question.
That's good.
When I choose the title of the presentation, as you see, is regarding standardization and certification, I need a motivation. And the motivation was given by the increase of cyber attacks on health systems. And here I mention only Killnet, but there are a lot of them. And complex architectures like CrowdStrike incident, which happened last year, when CrowdStrike is a big security firm, company, and release an untested update. And this untested update hit several airports and hospitals. And I don't know what I do. Okay, in this domain of security, we must be aware by Black Swan event. What is a Black Swan event? You see here, it is an event which cannot be predicted, which has an impact, has a major impact on the society, and can be explained only after its occurrence. Examples you see here from the rise of internet, dissolution of USSR, former USSR, Fukushima, Daiki disaster. These are examples of Black Swan events. And now if we are regarding 5 years ago, and maybe you can correct me, COVID-19 wasn't a Black Swan event, because there were signs that will appear. And the government were not to do everything what they can do, the best. And to protect, to answer to your specific question, to protect to this type of attacks, we need a model of the security. In fact, we need to protect data. And the first thing we need algorithms. Algorithms are designed by mathematicians. And these algorithms are implemented into cryptographic modules, like firewalls, for example. And these cryptographic modules are going to products. And products are assure an application and system. As you see, there are several regulations. And we must have the knowledge that we respect them. And how we can respect them? Only by evaluation and certification. At the European level, we have regulations regarding, this regulation is called NIS2 directive, and is implemented in whole Europe. And also we have European common criteria. Now I want to go only to the last slide, because here are several technical challenges in healthcare. I already talked about 5 no's in security. Know the value of your data, who access your data, where the data is stored, security measures and how they are, if they are effectively. The challenges are confidentially computing What means confidentially computing? I make a computation on the data without accessing raw data. Also, decentralized trust, like blockchain and intelligence automation, AI governments already talk here a lot. And also I must mention zero trust techniques. Why zero trust techniques? Because to avoid lateral movements into a system. And now, this is a key from my perspective, because if we looking to NIS2 directive, we have here the bandmaster, which has the IT team, the management, the governments, and the incident response team. The security, it is a process, it's not a product. I think I have answer to that.
You covered my answer. I would go to Daniel now, because it just came to my mind, can open source be a driver of cross-border cooperation, meaning there are many energies out there in the wild, ready to tackle different moments of crisis, as it happened during the pandemic. Can we put them together with a real, everybody's real specialists, but real specialists meaning legal persons, all together in time of crisis, just to bring together open source and legit developers of medical software?
I think, of course, so using open source technologies is an everyday business for every developer. So we are quite frequently adopting those technologies. Of course, we can extend it further with our own knowledge and with our own business models, but we can based on all these open source technologies. So definitely, I think that's a key part of the development every time.
Mr. Drury, WHO is listening, it's just listening. What it happens in this field, these people prepare here a lot of software, a lot of infrastructures. How do we cooperate with them? What can you tell us about what happened in the recent years about the cooperation with the private field?
Sure. So it's been an evolving process, but I think WHO has become much more open to collaboration with the private sector, and so it should be. But I would just say that the conversation that we've had for the last 40 minutes has essentially been about human health.
Absolutely.
As opposed to One Health. And the real challenge, I think, is to figure out how best to build on the successes that there have been in human health, and think through what is it that we can offer to colleagues who are working on the similar agendas of collecting data, sending it to the national government, dealing with the knowledge and policy that comes back, interpreting that in precise ways. How is it that we can work with them to agree an approach that brings together what we most urgently need to bring together, particularly to try and prevent disasters, or if they occur, then to mitigate the effects as quickly as possible. So COVID-19 obviously concentrated minds wonderfully, and it was a great stimulus towards One Health, because it made people realise that actually the interaction between human health and animal health, or insect health, is really, really important to understand and to get right and to monitor. Now, what I think WHO, in conjunction with the World Organization for Animal Health and two other organizations whose acronyms I forget, but essentially the quadripartite has been pulling together this One Health approach at an international level. And in due course, they'll get down to thinking through, okay, so what are the data standards that are going to need to be applied to actually make this overarching vision something that actually can be delivered on the ground? And I think we're some way away from seeing that happen. But my view is that to the extent that it is possible for countries, if countries are interested in doing this, but probably more particularly different communities within countries or counties perhaps within Romania. So I think there's one county that is represented in the brochure for ROHEALTH, but maybe there need to be more. So what is it that they can do to bring together the people whom they know, who are working in health, agriculture, veterinary practice, who are monitoring the environment, to bring them together and have the conversations about, well, what are the key items of data that we need? How do we identify places in a unique way? How do we leverage what can be available from GIS, for example, for that? And what are going to be the standards that we'll use to handle that data? So I think WHO is only one player in the bigger picture of dealing with One Health, and is yet, in my view, to really play a full part at the locality level. That's what I was indicating in the guidance. There's plenty of stuff at a national level, but it's fairly high level. It's about getting in place your strategies and your action plans. It's at the local level that you actually understand what difference it makes to bring together knowledge about what is preventable, what's treatable across these different domains. And it's at the local level that the mayors and officials are really at the front line when an emergency hits, when a flood hits. The health impact of floods or drought or some infestation by an insect, it's at that level that people really need to be able to understand what do I do? And we're nowhere near, in my view, having a coherent answer to those sorts of questions. So there's a huge agenda to be addressed here. Having said that, I do think, but I would say this, wouldn't I, because I spent my career on the human health side, but I do think there is an awful lot of good practice that can be shared and learnt from by others. But we have to be open and realise that actually there isn't that much time. Everybody talks about the impact of climate change, but it is happening at an accelerating pace, and that affects all the different health systems, human health, plant health, and it's accelerating, and one thing feeds onto another. So the pace of change is really increasing rapidly, and that's why I think this One Health agenda really needs focused attention. Strategically, human health, of course, absolutely is important, and we need to do what we can to improve how we plan and go about doing that. But if you think about where the major risks are going to come from, in my view at least, it's really around things that go under the umbrella title of One Health, both internationally, nationally, and particularly locally.
Some European countries are advanced, let's say, in this field, in collaboration projects, first of all, and then in very specific individual tasks and issues. I would ask you and Arne, which European model, because we have a Romanian audience here and also people online watching us, which European model is most relevant for Romania to replicate, if you know one, or if you have a personal opinion on that? And also for Mr. Drury, of course, because here we were.
You mean from the technological side? From the technological side, it's very simple, because there is international norms that have been existing for the past 20 years, and they are continuously redeveloped, readapted to certain things. And there is this HS7 fire standard. There is a huge consortia that also define of how data is stored semantically. One of them is SNOMED. There is different ways of choosing this. I think the main thing is you need to choose one. It's not important. We don't have to go into the intricate details of which is the best and which is most representative. We have, as a company, we have made our choices. The Americans have made their choices 20 years ago. Now it's our time to just follow one standard, and that is probably going to be fine. Yeah, and we just need to make sure that all future products, all future technologies that we're building is just following this one standard. And I can only answer for the German, also for the perspective of the European Health Data Space. FHIR has been the predominantly used in this space. SNOMED is very highly used, but ultimately every other standard would work as well, as long as it's updated regularly, there's licensing in place and so on.
Professor
So I can go into that more detail in my presentation if you want. But
absolutely. Professor Stefaniga, do you have a point here? Because you travel a lot, for sure, as an academic.
Peter is on the same way. I think this, if we need to give a name, the Estonian, I think, country, they had a strong health data space. But I want to shortly come back to Sorana said in the previous comments. It's not changing. It's not about changing the cultural settings, because it's a human-centric approach. I will say here, I work to changing the mindsets and to improve the communication, not only with the patients, but with the entire population. So the communication in health, I think, is the key of success. This is what I saw from my past experience during the COVID-19 pandemic. Thank you.
Yes.
Peter, if you want to add something.
Thank you. I too was going to mention Estonia, but not just because its human health side is good, which it demonstrably is, but because, again, I think it was 2000 or at the end of the 1990s, they quite deliberately took a whole-of-government approach to investment in digital. And that, I think, has stood them in good stead, and is why that whole approach, a whole-of-government approach, I think with a clear, consistent commitment right from the top. So this is the virtue of having a crisis where actually the Prime Minister does need to get involved to give a clear steer to resolve that's the opportunity that there is, I think, in taking a whole-of-government approach to improving the information infrastructures to address One Health. But essentially what I've also been saying is, in addition to thinking like that, think also about what can be learnt from dealing with a whole-of-local government approach. What would that mean if it was digital? What digital support actually could be provided to people who are working locally? And not just providing it, but stimulating the companies and the organisations that have an interest in improving that. So that's where the public-private connections can be played in as well. So, thank you.
Daniel, you wanted to say something?
Yes, I wanted to agree on that one, that we are working with an Estonian hospital in one of our projects, and obviously, as you mentioned, they are quite advanced on their IT part, on their public healthcare system. However, they are not really connected to other centers. So I think what this panel is about, data sharing and collaboration, it not stops at the national level. We have to bring together those countries, and even though if they have a different standard, we have to merge these standards together, not merging them, but in Aidava, in the project when I'm a work leader, we have a quite good solution on that one. So when we get to my presentation, I can address almost all of the concerns that I heard here. So I think it will be interesting for everyone.
Having in mind the time constraint, I am trying to tackle all the subjects you have prepared. But you see, everything is very dynamic, and even Alexander wants to add something. Not now. I saw your microphone picking up. So, Arne wants also to come up with his presentation. So let's try to round up things for his presentation.
I will just skip to the relevant parts.
Exactly.
Where is
exactly.
This thingy? Thank you very much. I think when I was invited to this this panel here, this conference here, I thought, okay, how could I contribute? I'm a medical doctor by training, so I come also from the data consumer side, not only from the data provider, and I'm also one of the co-founders of a company that is very active in the European health data space. So that's not me, but I can do this as well. Anyways.
Arne Paine.
Hane Peiner, that's me. Anyways, I think it's important to. It's also not me. should we switch? So
No problem.
they all look the same. It's the white one. Yeah. Anyways, so I think when we come from a data consumer perspective, we have to think about three main factors. We are medical doctors. We spend most of our times in front of computer screens rather than spending with our patients. That's what my colleague already said. It's 50% that we do data documentation work. It's something that we that's a huge problem. And rather we have around 1,000 data points per patient per hour at the ICU. So I'm an intensivist. That means 14 to 20,000 data points that are coming to me. And if you would think of a car that gives you 14 to 20,000 data points per hour, you couldn't drive anymore. That would be an enormous problem. So we need to tackle this in some way. Yeah? And the only way to deal with this is basically to make best use of that data and to use new technologies that can be digital technologies, that can be AI, to apply them to this problem. Otherwise, this huge wave of data that is generated will not be properly addressed. Yeah, and there is a second part to it, and that is there we are, great. So. This is the first thing here, 50% of our time just in front of computer screens. And the second thing is we have a demographic topic, that is the demand for medicine is rising. We have this topic of intensive care rising double by 2030. And it's expensive. The healthcare is an expensive system. People lose money and make money in the intensive care domain. So this is one of the most data dense parts of it. So we as a company and also I as a clinician are mostly concerned about this part of it. So there's multiple ways to address that, and I will not go into all of them of how we as a company do that. But I think what I hear here in all these discussions, that there is always two sides of the medal, two hearts beating also in my chest. This is the academic part where we have this entire area of new algorithms, as you said, new real world evidence that we need to bring together to the bedside impact, because everything like that we discover and that we develop in all these academic projects ultimately needs to get back to the patient as well to create acceptance. I think as long as we don't have in mind that all these results of data sharing come back to the patient ultimately, we will have a very hard sell in promoting data sharing if we don't give back to the patient. And I think this is the only way to deal with that. So we as a company, this is not an advertising moment, but I promise this is the kind of product we are manufacturing, and it is, think about it as the iPhone for the ICU. It's a system that the doctors and nurses use at the bedside to support them and give them basically access to AI, access to telemedicine, for example. And this is one of the systems that we built out of pure frustration of data interoperability, because in my first job we didn't have access to data at all. We spent all the time typing stuff from the computer screen into an Excel sheet. That was my first job, and this is not something that I could do for the rest of my life. So I said, okay, we are developing something here, and this is called this Mona device that we are selling. So the foundation of it, and this goes now more into this data interoperability part, is HL7 FHIR. So we built a system that's entirely founded upon the data model of HL7 FHIR. And as we strongly believe that the ownership of the data should get back to the hospital. So they are the ones taking care of the data, they are storing it, they are deciding what happens with it, and they are deciding whether they should comply or not. It's not the manufacturer, it's not the SMEs that say, okay, we rather do it this and that way. It is the responsibility of the healthcare system to have, to store, to maintain the data integrity of their own system. It's not in the hands of an SME that can decide what to do. So this is kind of the foundation in which we built, because there was no system on the market that existed here. We needed to build one ourselves, and that's what we have been doing for the past 9 years. And we do this pretty successfully, I would say, in multiple countries. Also very, recently also in Romania, we have the first 4 hospitals here in the area of Cluj that are actively contributing. We have now the first hospitals also in Bucharest. And everything they are doing at the ICU is then now stored entirely in FHIR and can entirely be shared amongst all new initiatives like the European Health Data Space. So one of the things that I wanted to remind you all is that there is legislation in place, and this is the European Health Data Space. It's not something that we make up or that we can think about for some years now. It is actual legislation that has been put into place by the beginning of this year, which will force us to live interoperability. There will be national law very soon that will tell you that as long as I have a legitimate interest in your health data, you need to share it. You have an obligation to do so, and every single part of the healthcare system needs to think about how can we adapt to that? How can we react to a request in 3 years where I say as an SME to your hospital, I want all your healthcare data on ventilators, and you need to provide it through the authorized bodies. That you need to answer this question at some stage, and this is a huge challenge. It's not an entirely Romanian challenge. It is a European effort that we need to go now and that we need to do, and we do it as a company as well in one of the projects right now. So you see also a lot of different countries here involved, but also quite a few here in Cluj and also in Bucharest that are contributing to this common idea of this European Health Data Space. We, as the company Clinomic, which is the company I'm working for, are contributing from the health data sharing perspective. We are providing the technology. How do we share anonymized, standardized data within these partner network, but ultimately also how do we share it amongst all the other partners here. And it is actually up here is very important. It's also supported by the European Society of Anesthesiology, and I think that's also one of the points that we need to underline. That this is also a question of regulation. It's a question of support of the official bodies. Say, okay, this is the way we want to go, because these questions that you have, there is nobody else that can answer those questions. You need to find your own answer, and then you need to promote it throughout your societies. So just that is one of the topics that we are dealing with right now. So basically, how do we have all this distributed health data that is stored amongst huge silos in these hospitals? How do we standardize it? How do we anonymize it and share it in a safe and sustainable way throughout Europe? It's the project, here's ICU Data for EU. We have the consortium meeting after 1 year by tomorrow, so it's also one of the reasons I'm here. It's a great effort actually to see how close Europe can become when we have data sharing in place, and also I think it's one of the beauties that when you collaborate on that level, that's also how close the doctors and nurses get together to see that it's not far away. It might be a 2-hour plane ride, but ultimately we are very close in what we are doing. We are caring for patients and for relatives, and not doing something very abstract. So that's one of the pros of this kind of initiatives here. And because I am still one of the founders of the company, there's also this link here if you want to see how we do it. But also maybe a word of encouragement, if you are interested in participating in one of those European Health Data Space projects and see how this is shaped, how we are progressing towards one common strategy, we're more than happy to speak about that later on. This was my 5 cents, maybe 7 cents.
Yeah, your presentation just cleaned the path for Alexander. So let's prepare his presentation as well. And now I'm asking Professor, just listening to Anne, you could highlight a possible academic bridge between research and practice, having all these actors on the European stage. A lot of things, so academic might be the missing link here in Romania. I think academic, yes, Professor. Academic could do more than they do now.
I think that everyone is needed to be implied in this process, not just academic. maybe you will see that academics is a central point, but not necessarily. Theoretically, the healthcare system is the central point, not the academia. And as our presenter already say, yes, if we have standards, if you have regulation, if you know that this is the path that we need to follow, we will follow, because any physician wants to see the patient, not to work on the paper. And if we can reload that work from the physician and to let the machine to do it, as Mona do it, yeah, because this is what is happening, yeah, collecting the data and put them together in a standard form. That is the main benefit of the healthcare system, because the physician really will have time to see and to hear the patient.
Absolutely. There is a huge interest for this field you approach, Alexander. So many people are asking during my TV programs for health about oncology, and you're about to tell us a few words about all-in-one platform for modern oncology practices. Be brief, please. Yes?
Absolutely. Well, thank you for inviting me, and I'm honored to be here to present you about DocVisor. At DocVisor, we haven't just built another data entry platform. We wanted to solve complex medical flows and enable collaboration between medical teams and ultimately the patient to make sure we handle all the challenges of the medical system, including the data that has to be entered within the interface that the doctor may have in order to pass it in. I won't go through the entire set of features. I don't think we have enough time. But we started with oncology just because there's been a gap there that was completely missing in the hospital. That I'm referring to the treatment prescription flow that uses a collaborative treatment protocols database where doctors can share information and can contribute to the same protocols database that has to be kept up to date with the guidelines. That further gets applied on a specific patient in order to create a prescription. It has to be communicated in real time to the pharmacy and further to the nurse to be administered. Of course, the electronic health record of the patient and AI destructuring of the information and communication systems that we've put in place can be used in any other fields, not just oncology. We've taken the advantage of using oncology because it was something that was completely missing, and hospitals really wanted to stay safe and make sure there's full traceability all the way to the pharmacy and the dosages are computed correctly and patients are treated safely. Now, data collaboration means not just, and we tackle in one of the modules this collaboration between oncologists and other specialties, because tumor boards are interdisciplinary medical committees where they need to share medical files with the other specialties in order to make the best decision for a specific patient. And they can do that in a very productive manner. They can do that online, they can do that offline, and discuss a specific case really quick, and at the end of it to sign a resolution and a report for the tumor board. I'll jump over the powerful report system. We have a really powerful scheduling system that automatically schedules all the treatments and all the treatment cycles, and they can see all the treatments and consultations in one place within a calendar that can also be synced within Google and other systems. AI destructuring of the information and making sure we use paper data, and it even interprets like handwritten text and extracts information with accuracy that can also be edited afterwards to make sure the data is stored correctly. And then you can use personal assistant to access any information you have about the specific patient. Of course, ultimately, the patient has to have access to its own data and has to have a productive communication with their doctors. So we've built this module for patients where they can see their medical records all in one place, and they can then see their scheduled treatments, and also be able to share side effects with their doctors in real time, and the doctors be aware of it. The online consultation module for the patients. I want to emphasize here what it means to use DocVisor. And on the left side, you see the statistics of it. So extremely safe dosage calculation, money saved on very expensive drugs, fewer time for patients to wait to get their treatment. And of course, on the right-hand side, you can see a breakdown of everything and why that happens, right? Because a lot of time is spent on documentation analysis, on assigning the treatment and calculating the dosages and following all the entire traceability all the way to the pharmacy. And these obviously save a tremendous amount of time, and ultimately it's the patient time that has to be spent in a hospital. And right now we are in more than 50 hospitals in Romania actively engaged, and we're growing. We want to tackle multi-specialties because a lot of functionalities that we built, I've heard somebody saying that it's easier to do a lot of triage instead of entering the data into a system. It's easier to handle it on a piece of paper because it's faster. We don't have time to enter the data. The consultation module that we've just launched recently that enables the doctors to be more aware about their patient and spend less time entering information into the system, so that the AI listens of the entire conversation, the entire consultation, and we are collecting all that information and then filling in the form for them. That's a really powerful tool that we use for the consultation report right now and for the 2 more boards reports.
Thank you. I wouldn't like to get closer to the end of this panel before addressing issues like policy, ethics, and the road ahead. I would like to ask Alexandra Dobre, how can civil society organizations ensure inclusion and transparency in data-driven health systems like the ones we saw during the panel?
For the beneficiaries, you mean?
Absolutely.
Well, as far as I know, because I work closely with, I think, all the NGOs who are developing projects for the elderly, I think they, most of them at least, they already have partnerships with all the institutions and other NGOs in order to assure this transparency that you are talking about. As far as the National Institute for Active Aging is regarding, we have a protocol with the National Directorate for Cybersecurity, for example, through which we assure the correct administration of the personal data and also the medical data, even if we don't actually collect clinical medical data. We just analyze the data that we have in order to use, I know it sounds odd, but we sometimes we actually have partners that are calling us to use our database in order to have some clinical studies, of course with their approval, with our members' approval, but we try to do these medical projects in order to help the companies, the medical companies, to have their medical studies, clinical studies. So I think we assure this transparency, and we do that through our partnerships and protocols with other NGOs and other institutions as well. And I think it's very important for us that, for example, we have more than 40,000 members. We are an NGO which was founded in 2020, and since then we reached more than 40,000 members. 80% of them are from Bucharest and Ilfov County, but we also have, thanks to the national campaigns that we developed this year, we have at least 20% of them coming from the other counties in Romania. And it is very important for them to be part of a community, and also to have, for us it's important to have their approval to use their data, their personal, and also when is needed, their medical data. I don't know if I answered the question.
You did, you did. If
Thank
you
you.
have something very specific which you came from home with some ideas, this would be the moment, because I want to prepare the...
If I say more now, I will not have nothing to say in my speech. So, if you allow me, some of, at least the answer for this question, I think it will be also in what I have to present later.
So let's
give me the
put
floor.
on screen the presentation as well.
Sorry?
I asked the guys, you have a presentation.
Yeah, actually, I know that I have 8 minutes for
No.
my speech, so I wanted to use 4 of them to say a few words about today's topic, and also to use the other 4 minutes in order to, we prepared 2 videos, short videos. One has 1 minute and 50 seconds or something, and the other one has 2 minutes and a half, I think.
I totally trust your judgment, so let's prepare it, and
Yeah.
we'll share thoughts with you on that.
In the meantime,
And we shall shorten a little bit the Q&A session.
in the meantime, I would have a question for Alexandra, if I may. If not, I can let the question for the final part. What's your strategy in attracting, I don't know, the people, or to convince the people to give you the data?
First of all, I think the strategy is in creating a community, because we all need to be part of something, right? So when we speak about the elderly, the main problem, I know that you will not believe me, but their main problem is not the financial problem, is the problem regarding the loneliness, because I think it's a loneliness pandemic in Romania. Most of our elderly people are facing loneliness. They don't have friends, they don't have their partner, maybe he or she is already gone. They don't have children, they don't have nephews. Most of them have their families abroad, and they see they can see them only through Facebook, TikTok, whatever, if they have the possibility to use these platforms. If they have internet, if they have smartphone, and so on. So what we do for them is actually creating this community. We have WhatsApp groups with more than 3,000 or 4,000 people. We have a Facebook group which is called Senior de București, Bucharest Seniors, let's say. I don't know if it's the right translation, but this is the idea, where there are more than 12,000 people out of 40,000, right, our members. So we also, what we also do for them is giving them free access to all of our activities, so they don't pay any membership fee, they don't pay any tax for participating in our national campaigns, in our debates, in our conferences, at the National Congress of Active Aging, which, by the way, is coming. It's next month, 17th, 18th of November, at the Palace of the Parliament. And we are also trying to open daily, not care, but daily centers for them. There are some spaces where they can come all day and do networking, socialize with each other. They can have lunch if they don't have the possibility to buy food, for example, we provide them lunch. We have more than 500 people in Bucharest where we go once a month or once at 2 months, and we give them the basic food products, right, in order for them to have food, because they don't have. We have a lot of elderly that don't have any kinds of income, not pension, they don't have a pension, they don't have any kind of income, so they really need our help. And doing all of this, we try to be close to them and not be as an institution or just an NGO who wants to, I don't know, gather money from the sponsors and do whatever. For example, me, I have a daily job. I am not paying my bills from what we do at the NGO. So I think this is very important, because all of the people that are involved, the volunteers, our volunteers, they don't live from what they're getting from the NGO. They have actually businesses, they have jobs. So that's why everything that comes in our account goes for the activities that we do, and that's why we afford to grant free access for everything that we do for them, at least.
Because the time constraints is there, I will point out again just a little bit how the national health priorities containing also involving also what you said goes to the EU for Health program, especially regarding preventive health and One Health coordination. Because as I mentioned before, in the morning we had the Ignosis CEO speaking about all these policies just come together, come closer one another. Maybe, Daniel, you have some ideas in the end of the conference.
I think that was not our company. Maybe. No?
It's
my CEO is sitting there and he says no.
Sorry. Yeah, sometimes it's a long day. Yeah, so it happens. It's my mistake, I apologize, no problem. We still have, let's say, 15 minutes to 20 minutes of Q&A session. If there are any questions from the room or from the online.
So, can you please let me do his presentation?
Yes, please.
Thank you. Could you please bring up the Ignosis presentation? Yeah, sorry for that, but I think you are talking about a lot of crucial things, and this project, what we worked on in the past 3 years, is connecting a lot of points, and I have to stretch my legs, sorry. Where is the... Yeah. Let me just jump over a bit. Huh? Yes.
It works.
Okay, so first of all, just let me introduce Ignosis. We are a Romanian SME, basically. We are a software developer company working on software development in the past 20 years. And we have 3 main business lines. I would like to highlight just one for this occasion, which is the R&D in healthcare. We are involved in 5 different EU projects. All of them is, 3 of them is focusing on federated machine learning, and what I would like to highlight today is IDAVA. This is basically a perfect example for data sharing and collaboration. Yeah, as I mentioned, public and private sectors has to work together. I don't know where I should say. Yeah. We have to work together. In this project, we have technological partners, private partners. We have clinicals from Estonia, Netherlands, and Austria. We have a patient association from Belgium. We have health data intermediaries from UK and the Swiss. So it's actually a quite European project. And basically what we want to achieve is what your concerns every time, that our health data is totally distributed around different departments and different formats. We have paper documents from general practitioners. We have laboratory results from medical private clinics, for example. We have electronic files in hospital or multiple hospitals. We have imaging data in CDs, DVDs. So everything is distributed. The question is how to harmonize, how to bring together all this information into one summary of healthcare for a patient. I would like to just show you basically the data flow, how it goes. In our case, we are receiving data from a health data intermediary. They are contacting patients as well and gathering all kinds of different information like GP data. GP data is shared with them in some of the countries like Austria, and they are collecting smart devices, information from that one. And this IDAVA system, what we developed, is actually deployed inside a hospital. So as I mentioned, in 3 different hospitals, Estonia, Austria, and the Netherlands. And we're receiving different format of the document, structured data, PDFs, and so on. And we process this information into a knowledge graph, which is using SNOW methodology, as you mentioned, standards everywhere. This is the future. This is what we need to use. So we are using SNOW methodology in the knowledge graph, and then from that one, we can extract different kind of outputs. In IDAVA, we have 2 different use cases. One of them is a breast cancer patient. So we can extract a BC breast cancer registry, and we can execute federated queries on these different registries. And for the patients in cardiovascular diseases, we are calculating the SMART risk score, which is actually a risk for vascular events. However, for all patients, we are extracting a standard IPS, which is using FHIR, again, standards everywhere, this is the future. And we are pushing this information over to the health data intermediary, so that means the patient will have control over the data again. And I will skip this. This is just how the application looks like, because we are releasing this in the next 2 months for the hospital. What I would like to highlight is, yes, the exploitation plans. How IDAVA can be leveraged in today's world, and how we can use this. So for example, this system, which converts legacy EHR system to new standards, like HR7 and FHIR, and OMOP also, it's an easy way, and there is a technological way to do this. And the other one is basically to create quality data with this tool. We can use it for predictive AI models generation, so we can train models on that one. So I think IDAVA connects all the issues what we saw here. Federated issue, it connects the paper data and everything. And I think this will be a good solution. And that's just to underline how much do we believe in this system. I think yesterday Bela already mentioned, but we are starting the first private Romanian biobank, which is based on federated data. And actually, if you scan the QR code, you can reach us, you can fill up the contact form, and basically get into the details of how the biobank will work. So I wanted to speed this up, sorry, but I think this is a crucial part, because this whole panel is about data sharing and collaboration, and this project and the new biobank will be all about data sharing and collaboration.
Data sharing is a trusted ecosystem. Technology enables it, but governance and ethics define it. So I want to apologize for not letting you explain all this, which are really very interesting. Now also the videos of Alexandra are ready. So let's come.
I think they are. I just wanted to point out that when we started in 2020, we were just pioneering in this field. I remember that I was going through from one company to another to convince them to donate and to support us, and they were like, what, active aging? Look at me, I'm only 40 or I'm only 50. I still have a lot of time in front of me, and I was like, okay, but you know, active aging is not about being at pension and dying the next day. It's about aging healthy and active and being in a comfort when you get to your 60s, 70s, 80s, whatever. And it was very difficult for me to convince people about this, about promoting this concept in Romania. Actually, I also have my PhD in this matter because I studied for at least 4 or 5 years best practice models abroad, and we have a lot of things to do regarding this subject. And after these 5-6 years, we are still pioneering, but at least people heard about us. They come at us, companies, institutions, beneficiaries. And I think that now it's not as odd as it was 5 or 6 years ago when I was speaking about active aging, because then was people who were promoting smart cities. You remember? If we go back 7-8 years ago, when we were hearing from somebody this subject, smart city, we were like, what is the smart city? And now everybody talks about smart city. It's very fancy and it's very useful, actually. But that's why I just wanted to point that out. Yeah. And now, unfortunately, it is not translated into English, but the photos are speaking by themselves. This is from the cybersecurity campaign, national campaign.
seniorilor, în special a seniorilor, pentru că, după cum s-a văzut, viața activă a seniorilor se caracterizează printr-o nouă viață conectată cu tehnologiile digitale. Este o chestie foarte interesantă.
This campaign was supported by ICI, the National Institute for Informatics Romania, and also by ECDL Romania, by BCR, by Czech Bank, by Garanti Bank.
Națională de Cercetare în Informatică, ICI București, a venit să susținem demersul acestei asociații de pregătire activă a bătrânilor și vrem să-i susținem să înțeleagă care sunt adevăratele riscuri și vulnerabilități în cadrul mediului online.
They learned how to navigate safely on the internet, how to use the technology safely. And of course about the personal data, the importance of protecting personal data. Okay, and I think the other one, if you can share with us, that other one is from the national campaign that we had this year in 15 counties in Romania, regarding the importance of prevention in health. This is from Constanța, I think. This was supported by Merck, MSD, Terapia. Thank you so much. It's just a little bit from our work. Thank you so much, Flaviana, for inviting me here and for believing in me and in my project in the National Institute for Active Aging. I'm deeply honored to be here, and I want to congratulate you and your team for organizing this huge and very, very important event each year, actually. Thank you so much.
The room, if there is any question. Yes, please.
As you know, Romanian hospitals received in the last 2 years a lot of money for digitalization from the National Plan for Resilience. And the idea is that each hospital decided what equipments to buy and the software they needed to buy. But I didn't see from the public information if all these equipments, all of these solutions, software solution, they ensure the interoperability between the hospitals, because we are discussing about electronic health records. And from the point of view of the patient, I know my mother, when she goes to the hospital, she takes with her like a plastic bag full of papers. So how we, Romania, we can assure this data sharing and collaboration between the public hospitals, private hospitals, and the public system, because now we are reading in the press about the healthcare insurance house. They still have problems with their system, national system. Which solution do you propose to integrate all this fragmented data? Yeah.
Anyone willing to answer? Professor Borbak.
Yeah. It's a good question, because digitalization was starting and each hospital put on the plane whatever they wanted. And they also missed the standard that they need to follow. So in this moment, I don't think that we can talk about putting all the data from the hospital together from this point of view, because the interoperability is nowhere. The answer is simple. It's legislation. If you put in the book that you need to follow something, you will follow. It's simple like that. Yeah.
I think that's also something that we need to see in public tenders, because the huge governmental contracts don't come from thin air. They come usually out of large consortia. They have been discussing extensively what they want, but this part of interoperability is often added at the last second and say, we will do it somehow later, hope for the best. I think it's also a question of education. It's a question of like teaching, like explaining the concept of interoperability again and again in formats like this, but also maybe in other formats where more buyers are, because ultimately the hospitals decide what they want to buy, and this needs to be one of the most dominant parts in public tenders. And as long as we don't have that, you will not receive it. You will receive something, but not what you want, and what brings you also a future-proof solution.
Any other questions? Okay, it comes to me to round up. A final question would be like this. What single action would you recommend to make Europe's health data ecosystem truly collaborative by 2030? I had to squeeze so many interesting subjects in only 2 hours, less than 2 hours. So I give you the time to think of such an, let's say, summarized question. Like, what single action would you recommend to make Europe's health data ecosystem truly collaborative?
Let me kick off on this. So I started at the outset. This is data sharing collaboration for One Health solutions. I said Europe has a lot to learn from what has happened on the human health side, and it's taken a long, long time to get to the European health data space legislation. I would encourage Europe to start thinking seriously about what a European One Health data space would need to start looking like. And it'll take at least 5 years to begin to formulate that. But actually, as I said, time is pressing. We really should not be wasting time without paying regard to the increasing pressures that are going to come on all our health systems from the natural environment as well as from a demographic that is aging as well.
Professor Bolbakova.
Harmonization.
Pick one standard, make it a law, force everybody to adhere to that law, and then continue the journey from there.
I think compliance and regulations are really important, but it's also very important the speed at which you deliver and you make progress. And you don't want to, as a European Union, you don't want to stay in the front of progress, but at the same time, you also want to fasten those processes for companies to be regulated and stay compliant.
I can repeat also what you said earlier. It's actually picking a standard and going with that standard and using that standard and forcing that standard to be mandatory at each of the hospital and each of the clinics and to provide their because if you follow these standards and you adjust your data according to that, then you can share this information with others. It is easily shareable. After that, you can push back all this information, all the patient's data back into the patient's back to the patients in a formatted, well-structured output, basically.
I would also add creating ecosystems, because I think we cannot have progress one without the others. So we need to work together, institutions, NGOs, patients, doctors, the elderly, the youngsters. Everybody has to work in an ecosystem. So creating ecosystems would be my answer.
I will vote, or I will vote for sure for legislation, but I would say we have many ecosystems. So now we are in one ecosystem, ROHEALTH, who is facilitating we have functional, I think, but we should have the specific legislation. After that, a strong commitment will solve all the issues.
Start with a real security audit. Yeah, regarding all the hospitals, in all the research institute, because we must respect NIS legislation.
Thank you very much all. Let's all together thank our panelists, Mr. Janusz Daniel Dalos, Ms. Sorana Bolbakă, Ms. Alexandra Dobre, Mr. Peter Drury, Dr. Arne Paine, Mr. Emil Simion, Mr. Sebastian Stefanigă, and Mr. Alessandro Lazar for... No, not me. I'm okay in the end of such a challenging debate. For one single enemy for you, you are 8, I am 1. So let's hope everything was fine. Let's hope each of you had the chance to say what you wanted. Thank you. And now let's have a picture together.